Welcome everybody. Professor Chris Baines, my name. Professor of Digital Health at Monash and lead for our Alliance for Digital Health. And I'll be the host for today's session about pillars of value in digital health. Sorry for a little bit of a technical glitch for you coming on. I'm sure some of you will keep coming on as I'm speaking just at the start. We've delayed that a couple of minutes to let a decent critical mass get into the virtual room. Just like to acknowledge that our Australian campuses of Monash University are located on the unceded lands of the people of the Kulin Nations, and Monash University and myself pays its respects to the elders past, present and emerging. And I'd also like to acknowledge I'm personally on the lands of the Wurundjeri people today in the northeast of Melbourne. Just a bit of housekeeping for today. We certainly have a panel session in the second half of the session today after a small break, which will hopefully start about 2:20 p.m. You can ask questions towards the end of the speakers' sessions. If we are running out of time, though, we'll hold answers to those questions over to the panel discussion. So please don't be dismayed if we're not answering the questions. If we do have time as each of the speakers talks, we will, of course, try to answer those questions for you. Next slide, please. So just a couple of scene setting slides. So in recent years, I've been quite interested in this issue of how we generate value from digital health, starting with how we embed it into our procurement processes and our design processes. And I'm just putting up in front of you all here, and many of you will form different or wear different hats in attending today. Everybody in the ecosystem should be concerned about value from digital health, whether you're a patient or a consumer or a clinician or an administrator or funder, whether you're building solutions or researching them or whether you're a vendor. Everybody should be having a stake in the value game and should get a benefit from the delivery of value. Next slide. And as part of that, I sort of conceived of this new area called value-based digital health. Obviously, there's great synergies with the concepts of value-based healthcare, but there's many things people are working on in relation to value-based healthcare that have nothing to do with digital health. I'd also argue there's some additional complexities about delivery of value from digital health solutions as well, which beget specific focus. It's really an intersection area between digital health itself, health technology assessment and health economics, and even information systems. So the information systems discipline has been looking at value from IT for decades in quite a different paradigm to the HTA paradigm, but potentially can be complementary. Next slide. And personally, I've started to talk about aligning the desired outcomes of value-based digital health solutions with the quintuple aims of healthcare. It's an interesting exercise to do that. We might end up in quite a different place, but it's not a bad starting point. One of the gaps I see there is an overt mention of quality, which of course tries to be implicit in everything we do in healthcare. And interestingly, a colleague of ours from Brisbane, Sandeep Reddy, the other day proposed that we should now be looking at a sextuple aim, and that should include sustainability. So that's something for us to think about as well. So sustainability from healthcare solutions. We will hand over very shortly to our first speaker. We're really delighted to have Zanfina with us. She is one of the true experts in this whole area of HTA and health economics. Just to give you a bit of context about Zanfina, she leads the Health Economics and Policy Evaluation Research Group at the Faculty of Pharmacy and Pharmaceutical Sciences at Monash Uni. For those of you who don't know, that faculty is routinely ranked at number 1, 2 or 3 in the world. Zanfina's research focuses on improving health and welfare and reducing inequities through robust health economic and epidemiological evidence for decision making. And she sits on some very important national committees. With that, I shall hand over to Zanfina.
Thanks, Chris. Thanks for the invitation to talk today. I just wanted to make sure, can people see my slides?
We're seeing your presenter view, Zanfina, that's all.
Is it good?
Better if you go to swap displays. There you go, perfect.
Okay, perfect. Thank you so much for the invitation. Just wanted to highlight some conflict of interest before I start my talk. I'm the member of the Economic Subcommittee of Australia's Pharmaceutical Benefit Advisory Committee, member of Lipoprotein A International Task Force, and professional member of Familial Hypercholesterolemia Australia. So just before we start, I wanted to give you an overview what I'm going to be talking today. It's more about the architecture of HTA that is currently in the Australian healthcare system. And I'm going to be covering also a couple of case studies where we can potentially improve our HTA processes. And I will give you an example of challenges of digital health that we have had recently with a future MRFF funded project in Australia. The HTA in Australia just recently had a review last year. So I'm going to be covering a bit of it, what we're doing well, and what are some of the challenges that we are going to be facing with respect to PBAC and ANZAC in Australia, and how digital health can actually learn from this, or some of those things be applied in a digital health space or not. So in terms of introduction, as you all know, the Australian government is responsible for funding medical services that are listed in Medicare Benefits Schedule, and health technologies subsidized and funded through PBS, Life-Saving Drugs Program, and National Immunization Program. But today I'm touching base only on MBS and the PBS. So as you already know, for the technology, first of all, to enter or be accessible to Australians, first you have to have an authorization through Therapeutics Goods and Administration. But this is only the first part. If you would like your technology to receive a public health funding, so it must go through or assessed through HTA bodies. But if this technology actually has a financial impact that is higher than 20 million per year, then the Minister for Health requires a cabinet decision. So there are two main HTA bodies in Australia. As you know, it's Pharmaceutical Benefit Advisory Committee for Medicine and MSAC, Medical Services Advisory Committee for First Services and Technology. So each of these have economic subcommittee and ask for the PBAC, and MSAC also has a PICO advisory committee, details to follow later. So in terms of the HTA reimbursements, sponsor usually sends the submission for funding. From this submission, the HTA body needs to understand who should access the health technology and whether it will work as well or better than the existing standard of care, because you might have a standard of care established in Australia, or you might not have at all. So you are comparing to a placebo, and whether Australians will be better off overall if it's this funded in comparison to other funding opportunities. So basically, what is HTA committee looking or advises on the question: does it improve patients' outcome, safety, or satisfaction at a reasonable cost that individuals and a community can afford? So submissions go down a particular HTA pathway, an advisory committee, so PBAC or MSAC. So it depends on whether how the technology will be used or provided. So there are 4 stages of HTA that play a crucial role when a sponsor sends a submission for the HTA evaluation. First of all, the PICO, population intervention and comparator, has to be very specifically defined. And this is always the problem, especially in ASK, because sponsors develop models, global models, and then they bring those global models to Australia. And sometimes they are not feasible, either because the population is not the same or either the comparator is not the same. So then PBAC sponsor develops the PICO without no stakeholder input. So this is the difference from MSAC, where PASC seeks inputs from stakeholders, including patients, carers, clinicians, to develop the PICO question. The second method that has an impact on HTA methods is conduct the clinical evaluation. So obviously that includes safety, efficacy of the technology, and compared alternatives that are available at that moment. As you all know, we prefer to have an RCT evidence, randomized clinical trial evidence, to assess this health technology assessment, but sometimes some other forms of evidence are available, such as real-world evidence, where randomized clinical trial is not plausible to run, especially in a lot of cancer treatments. So the third method that plays a crucial role in HTA is conduct economic evaluation and financial estimates. Australia, as it stands, mostly used cost-utility analysis and cost-effectiveness analysis to assess whether the new technology provides a better value for money in comparison to standard of care or placebo. There are other conditional or consider additional value elements in the HTA method. So confidence in evidence and assumptions of the submission, because sometimes new technologies might have 2 or 3 randomized clinical trials. Some of them might have only 1, or some of them might have only real-world evidence. So confidence in evidence and assumptions is critical. Equity of access issues such as age, socioeconomic and geographical status, this is assessed only at a quality level, not quantitatively. And then also we look at the presence of effective therapeutic alternatives. And also for the technology to be reimbursed, we look at the severity of medical condition, if it's a rare disease or if it's a very prevalent disease, and also feasibility of implementation to target proposed therapies precisely and effectively to patients that are likely to benefit. And also public issues such as antimicrobial resistance, consumers' comments regarding the main benefits and harms of the proposed benefits. So consideration of additional values, elements, HTA guidelines allow for additional information. They might influence decision-making, and those might come mainly from clinicians or consumers or issues in relation to equity, ethics, access, or public health. However, according to the recent review that is out, there is no guidance on how sponsors should present that information when they submit the technology. So it's not as clear as you would do, for example, for clinical evidence, health economic evidence, and so forth. So HTA make value-based assessment that incorporates these broader value domains qualitatively rather than quantitatively in the decision-making. And there is no guidance on how HTA advisory committees consistently consider and apply this information. So as mentioned before, there are different, obviously, evidence that are considered in HTA. Sometimes randomized clinical trial evidence is sufficient. In some instances, it's not sufficient, and we have to look beyond it. And usually where we look is real-world evidence data. So now moving into the stakeholder and patient and public engagement. So for the PBAC and MZAC process, consumers and health practitioners and any other interested group of or organization can provide impact to PBAC and MZAC on committee agendas, hearing about specific medicine submission, expert clinical consultation, and formal stakeholder meetings. However, as I mentioned before, and also the HTA review pointed out, it is unclear how submission from consumers are used and what impact they have. Because sometimes we ask question, does it have an impact 5% or 10%, how we swing the decision making, and that's not quite clear at this point on time. So there is a lack of formal and routine involvement of First Nations health representatives. So this was a big thing that came out of the review. So particularly in the PBAC and the MZAC, this is particularly contributing to the health inequity in Australia. So the timelines for HTA, the time for a new medicine to be listed on the PBS depends on the key steps. Global launch by the pharmaceutical company. I'm not sure if you're aware, but majority of the new treatments that come into the market, first of all, such as US, Europe, or Asia. Australia lags a little bit behind in terms of launching new treatments into the market. So submissions sometimes can go directly to TGA, and sometimes they might even have PBAC and TGA parallel processing. So TGA review and approval, and then PBAC application and recommendation, and PBL listing post PBAC approval. But you have to know that many new medicines require multiple PBAC submission before approvals. And sometimes, as I mentioned, those new multiple submission relates to either how the model is designed, might be global, it doesn't represent the Australian population, the comparator is completely different, or the study population that is included, it's probably not similar to the clinical trial, or it's not similar to the real world practice that is in Australia. But for this multiple submission, we provide feedback to guide resubmissions. Major therapeutic advances often need 2 or more submissions, and usually it takes sometimes more than up to 95 weeks for TGI application to the positive HTA decision making. So it's a quite long process. Sometimes some technologies might even take 5 years. So for advanced technologies, such as highly specialized technologies, cell and gene therapies that are delivered in public hospitals, first of all, there will be a sponsor briefing, and there might be a joint chairs of committee of MZAC and PBAC, and then MZAC application to determine if MZAC or PBAC review the therapy. The process is not quite clear. It's emerging at this point in time. And it has a lot of implementation challenges alongside. Probably all of you are aware that in Australia or in health economics, we use discounting, and discounting is something that we use to reflect the assumed societal preferences for current over the future benefits. So if you want to implement something that will have an impact on a future population of outcomes for Australians, we need to discount the costs and outcomes. Australia, as it stands, has a base case rate of discounting of 5%. It's one of the highest that it is to date. For example, just as a comparison to other countries, UK uses a discount rate for outcomes and cost 3.5%. The standard World Health Organization one that is used in a lot of low and middle income countries is around 3%. There are other countries, if we look the other HTA guidelines, for example, Netherlands would use different discounting for cost and different discounting for outcomes. So usually there is a flexibility when HTA, the sponsor submits the HTA. Sometimes they can provide different discounting rates, but the base case is 5%, but sometimes 3.5% or 3% previously have been accepted. However, there is no explicit guidance on how this flexibility is actually exercised in a guidelines and how that impacts on certain technologies that are reimbursed. And this came out of the HTA review. So in terms of the architecture, so the HTA process is very reactive. So it's driven by the sponsor. There is no formal horizon scanning at the national level and no funding for such arrangement. And this is something that we lack in comparison with Europe. There is a lot of European horizon scanning for different technologies. HTA process review is ad hoc and infrequent. Major HTA reviews are completed for 2024. There are some capability challenges, growing volume and complex technologies that are submitted in MZAC and PBAC, and this makes a very challenging to review and time consuming. And we need a greater health economics capacity to be able to deliver those things on time. And for all of you here, health economists are involved in price negotiation, stakeholder engagement, listing process, and pre and post HTA evaluation. So in terms of choice of comparator and why cost effectiveness analysis and cost utility analysis in Australia, usually sometimes some technologies might not have a comparator, then the net difference between the new technology and no standard of care, it makes incremental cost effectiveness ratio not very appealing. But HTA take those into consideration. So Chris, you mentioned the issues with equity, and I think this is one of my favorite topics at the moment. So equity-informed economic evaluation and why this matters in Australia. So traditional economic evaluation focus on average cost effectiveness, often overlooking disparities and health outcomes across different populations. So we don't generate incremental cost effectiveness ratio for different groups. We generate a single cost effectiveness. So equity-informed evaluation consider how intervention would impact different socioeconomic groups, ensuring fairer resource allocation, because some groups might need more than the others, and help address health inequalities by prioritizing interventions, supports policy decision-making. Some HTA agencies incorporate distributional cost effectiveness analysis to assess the trade-offs between efficiency and equity. But at this point in time in Australia, we only consider equity in a form, in a qualitative way, not in a quantitative way. Health technology assessment bodies in Australia globally use cost utility and cost effectiveness analysis to estimate the value for money based on specific health outcomes. So these assessments do not typically include indirect and non-health benefits. So basically, we don't include the broader societal value in the base case analysis. And this is something that I work quite a lot myself to define other typical, other non-traditional outcomes that we should use in a value-based healthcare. In terms of equity, I just wanted to highlight that Australian guidelines allow for qualitative equity. Only the Indian guidelines incorporate equity concerns into the reference. You might ask the question why Australian HTA guidelines don't allow that. First of all, we have to establish population norms about equity in terms of quality adjusted life years, and these are coming soon. And the second of all is workforce. So we need to train those people who assess HTAs to understand distributional cost effectiveness analysis. That will be a big challenge for Australian government to implement such a thing. So as mentioned, the Indian guidelines incorporate distributional cost effectiveness analysis. In other countries, equity only quantitatively incorporated from a disease severity perspective. For example, in NICE, Netherlands, and Norway. There is current HTA in low and middle income countries and in Asia. Equity quantitatively is still in early ages, and it's with a very limited equity informative assessment at this point in time. As mentioned about Australia doesn't consider indirect cost or productivity losses cost in the base case analysis. However, they consider it in supplementary information if sponsor would like to provide such information. However, there are countries who consider productivity in a reference case, such as Taiwan, Sweden, Netherlands, and Spain. Most exclude productivity from a reference case. As I said, Australia, England, Wales, Scotland, Canada, New Zealand, France, Germany, Norway, Belgium, Japan, and Singapore. And this has a huge implication. So now I'm going to go through this very quickly, Chris, 3 case studies. Why productivity adjusted life years? At Monash, we have been developing this new metric, which is called productivity adjusted life years. We are pushing forward with the idea that productivity should be included as an outcome measure for decision making rather than as a cost. So we've developed this new metric, which is called productivity adjusted life years. So what does it mean? So we are calculating the productivity index that ranges from 0, somebody being completely unproductive, to completely productive. And this, to generate PALI, you usually multiply with years of life lived. So look at this graph in here. You have productivity 0 to 1 and time horizon, let's say 10 years. You have somebody with a working life with a condition and working life without condition. There is a huge gap. And over the years, we've shown that some analysis where we compare the QALYs lost and PALYs lost are much more higher in a different condition. So this is something that we are pushing forward, and a lot of MRFF programs that we have been part has used this productivity adjusted life years, and we've been very successful with it. As mentioned before, the preferred evidence that HTA requires is randomized clinical trial evidence, and when that evidence is not possible, we have a real-world evidence. But I want to bring to your attention something that is quite novel, and we've been using quite a lot, which is called Mendelian randomization. And Mendelian randomization used genetic variances to randomize individuals with high and low risk factors and how they have an impact on outcome. And Mendelian randomization is similar to the clinical trials and offers solution when RCTs are impractical for delivering causal effect on health economic models. And this helps address limitation of observational studies in estimating risk factor modification. And this is where I see, for example, digital health monitoring of risk factors can have an impact on using such evidence. And the reason why I'm pushing for this is that these methods combine disease biology and the knowledge of epidemiology and evidence for causal inference for observational data. And it's also very important for designing the models that incorporate long-term effects of risk factors on a disease risk. On a final note, I would like to sort of conclude with the Australian Epilepsy Project. Australian Epilepsy Project are on a mission to change the lives of people with epilepsy. They've received 30 million grants from MRFF Frontiers. And Australian Epilepsy Project is a typical platform that doesn't actually goes into traditional processes of HTA, either via MZAC or the PBS. So this has been a challenge because it's a brain healthcare platform that translates epilepsy research into clinical outcomes at the population scale. So basically, it combines advanced imaging and cognitive techniques, but we add their genetic data, AI, and then we spin it in the AAP platform to better predict outcomes for people with epilepsy. And this actually can reduce the time of diagnosis and reduce the time to seizure freedom. And we know that more than 50 million people live with epilepsy, but with the current data that we've shown is that people wait in average 7 to 10 years to actually become a seizure-free, and approximately it will take them around 30% of them still remain a drug-resistant life. So what we've shown with this data that even a small changes at the population level can be or can lead to a cost and billions. So we've been working quite closely with industry, with government, but this is a platform, digital health platform, which actually finds it very difficult how it can be integrated at the federal or at the state level. So in summary, so emphasizing digital health, integrating technology to enhance healthcare and accessibility. So with this, what I mean is, can we use some of those techniques and methods that we apply in the traditional HTA to the digital health? And obviously, Michael is going to be talking more about patient-centered outcomes and value in healthcare and focusing on what truly matters to patients. Should we actually consider those? Beyond traditional health metrics such as QALYs, I touched based on things such as productivity, adjusted life years. Can we go beyond QALYs to introduce equity-informed decision-making quantitatively? And do we have a scope for that? I think we have to initiate this discussion to see, do we have a scope or do we have an appetite in Australia to do equity-informed decision-making? Diversifying the evidence, as mentioned, utilizing real-world data, yes, but also we can find other alternative approaches, as I said, Mendelian randomization. And this actually came quite strongly in HTA review, First Nation Health, focusing or ensuring inclusive and culturally relevant health assessment, formal and routine involvement of First Nation health representatives on HTA bodies. Thank you so much. I would like to thank Sheridan Rhoda and Donna Hutchison for helping me to prepare this slide. Thank you.
Thank you, Xanthina. That's wonderful. I've been digging into this space a lot, and I still got like 2 pages of notes from your talk. Xanthina, how much longer are you on the call for before you duck off, just roughly?
I will be here until 2:55.
2:55?
1:55, sorry.
So just for our audience, if you want to ask any questions of Xanthina in the next sort of 15 minutes, then she will be ducking off for a while, coming back later. But feel free to type those in. Thanks very much, Xanthina. Next, I am going to introduce Associate Professor Michael Franco as our next speaker. Michael is a consultant physician, informatician, and National Chief Medical Officer at St Vincent's Australia. And importantly, he's actually, it says that here, formerly the Executive Director of Digital Health at Monash Health, and I worked with him closely there. Michael is passionate about innovation, having led projects on AI governance and its application to healthcare. So Michael's going to be able to bring unique perspectives, both as a clinician and as an executive. So I shall hand over to Michael now.
Thanks a lot, Chris, and thanks for the invitation. I think, sometimes bios can be long-winded and embarrassing, but I think in this case, it's particularly relevant to my talk. I guess I've had a career in healthcare that spanned, and actually pre that career that spanned quite a few different things that I've done. And really today, I wanted to bring some of those different perspectives into the room and just compare them and contrast them against each other. So nothing I'm going to be saying today is particularly earth-shattering, but it's more an opportunity, hopefully, for all of us to maybe just consider some of the different perspectives as well as our own perspectives when we're thinking about value in healthcare and what that might mean. So I'll go to the next slide. Thanks. So, unsurprisingly, we generally think about value as being an outcome or a benefit divided by the cost of doing that thing, whatever those costs may be in whatever way, shape, or form that might take. The obvious form of dollars, but that might be time, that might be effort, that might be other things that are invested in doing a particular thing. One of the really interesting things when we consider the value equation in healthcare is asking ourselves the question, well, what's the numerator here? What are the outcomes that we plug into this equation when we think about it? And what I'd contend is it's really different for different stakeholders. So the key stakeholders I'm going to touch on in brief today are patients, clinical staff, hospitals or care, and I've put hospitals for simplicity there, but any providers of care that might be acute, subacute, community providers, primary care, and others. So care providers at an organisational level. And then obviously government and regulatory bodies, and then vendors as well when we're considering digital health. I'll touch just sort of briefly on my journey, because these are the three perspectives that I'll bring into the room in particular a little bit later. I've had a certainly pre becoming a clinician myself, a long history of being a patient. When I was a kid, sort of between age 11 and 21, 22, I spent a lot of time in and out of hospitals, GP practices, specialist rooms as well. And so I remember that very, very acutely, and bring some of that knowledge and lived experience into the room. And as well, like, so that, wouldn't be unique to me. There's many of us here that would be doing that, and often because of that, we're attracted into working in or alongside healthcare. And I've got similar experiences as a carer with family over years as well, again, as most of us do, and sort of think about value and what's been valuable to me on that part of my journey. Then obviously as a doctor, medical oncology, palliative care, but also as a junior doctor, and then as in the mid part of my career as well, thinking about how the things that are important change once you're on the other side of the desk, or standing or sitting at the bedside instead of in the bed. And then as a hospital executive, and as Chris said, I've been lucky enough to be in a few roles now, that have given me the perspective of what's important and what people value when it comes to an executive room in the boardroom. What sort of things provide value or are seen as valuable there as well? And I think interesting to contrast some of those. We'll go to the next slide. So the specific, again, fairly straightforward, but when we think about some of the ways that we might measure outcomes for those different groups, in gross terms, for patients, our objective quantitative measures that we have are patient-reported outcome measures and experience measures, so our PROMs and PREMs, and they are often they are very valuable ways to measure what that experience of being a patient's like, and what the outcomes are. So really pleasingly, PROMs and PREMs wasn't something we talked about until about, I'd say about 8 years ago or so. And we've started to see them be more and more embedded in clinical systems, in clinical practice, and also more routinely collected and provided at various levels of the healthcare system to help us understand what it's like for patients and for consumers, and in terms of how successful we're being, both in objective and subjective ways for that critical group. Then clinical staff, and so I'm talking about all clinical groups here, not just doctors, but nurses, midwives, allied health, pharmacy staff. We think about, in the main measures that we see are staff satisfaction surveys. They can take many different shapes and forms. They can be done at state and national levels. They might be done at an individual health service or at a university as well. How satisfied we are, and doing those at regular intervals can provide really important trends of how of what value is being provided to those staff. At a health service level, I think about accreditation outcomes, or outcomes from accrediting bodies, and we've got obviously multiple different levels of that, everything from individual health services to entire specialties, and I think about our national standards. Other things that have become more and more important over time have become HACS rates, or hospital acquired complication rates, as a really important measure of what value we're providing at what cost, for patients and consumers. And I think one of the important things, having a reasonably well standardized and well agreed definition of which hospital-acquired complications are the ones that are important, that we're going to track, that we're going to measure, and that we're going to report, at least certainly within different jurisdictions. So in Victoria, that's well defined. There is an analogous set in Queensland and New South Wales. They're different around the edges, so we haven't got standardized reporting right across the board, but some distinct similarities, which has been really useful. Other mandatory data that's reported, and then I think about when I think about at St Vincent's, when we have private hospitals and private healthcare as well, thinking about specialist visiting medical officers and patient popularity measures are also really important measures of value as well, and ones that I really didn't think about anywhere as much until in my public health and academic life, and obviously return on investments. So simply looking at ROI and bottom line. Governments, so population health measures that in all ways, shapes, and form, budget deliverables, popularity of policies, and I think really, measures of health equity as well, as Anthony is so beautifully articulated in the previous presentation. Then vendors are generally focused on revenue and growth and market share. So you can see that simple equation of value can mean very, very different things when we start digging into it. Next slide, please. Again, then thinking about value through, as Chris has put up at the start and contended around the framework of the quintuple aims of healthcare, I wanted to then sort of pass the different perspectives through the quintuple aims and just maybe draw out a couple of things in brief. So quintuple aims, as most people here will know, and Chris put up, but I'll just go through them in brief again. Enhance patient experience. So those classic PREMS measures are a really good way for us to track that. But as Chris has rightly pointed out, one thing that's not necessarily captured there is quality and safety outcomes at an individual patient or hospital level. We need to wait till we get to the second health outcome of the second of the aims, improve population health, before we start to really be able to track quality and safety. And that's then once we've extrapolated it to population data, that's useful, but it's not very immediate. It takes a lot of time in general, or at least some factors of units of time for us to see changes that we make in more frontline healthcare filter through to changes in population health. So whilst that can be a useful measure of quality, efficacy, and safety, there will always be a lag in seeing the effects in population health data. Reduction in costs, fairly self-explanatory, but I think an important one, and one that often as I think clinicians generally and health services, and I think patients as well, have become more comfortable talking about. It was really, and still to a great extent, clinical staff don't like thinking about the cost of things. We just want to think about, I just want to provide the best care to my patient. I don't care how much it costs. That's just what I'm here for, is not to be an accountant, not to be the chief financial officer, but to provide really good care for patients. But I think that is somewhat changing a little bit for the better. Rather than being that black and white, I think there's greater and greater appreciation that we need to think about our healthcare systems in a sustainable manner. There's more acceptance that if we just continue what we're doing and providing healthcare in the way that we're providing it, it's not going to be sustainable. We know that we've got increasing population, aging population, the measures of health equity that aren't improving in particular areas. And if we just keep going, okay, the only way to make things better is to do more of the same, is to build another emergency department, build another hospital, pay for more doctors and nurses. I think there's a much greater understanding and acceptance, as there has been for some time at system and government levels, that we really can't have a sustainable system. We will have a system that we will have to be making choices about our healthcare that we don't have to make now, unless we find more sustainable ways to continue to provide exceptional care to a ever increasing number of people who need it. The other thing I'll say is it's not just the number of people that we have that are needing healthcare, but we're becoming happily a victim of our own success to a great extent. We are keeping people alive longer with conditions like cancers. We are doing better at treating patients with chronic cardiovascular conditions or neurological conditions. So it means that we've got not only just a simply expanding population, but an increasing complexity of that population as well, who are on and having treatments for chronic diseases rather than things that potentially were life-limiting in the past. Number 4, care team. The fourth aim, care team wellbeing, relatively self-explanatory but desperately important these days. We know that we've got we know that we've got data around clinical staff in particular, and levels of stress, levels of job satisfaction that are struggling and have struggled, really took a hit during COVID and have continued to struggle. Now, I think it would be fair to say COVID was really just a catalyst. It was not the reason that we now all of a sudden have people leaving healthcare. And attention to well-being for clinicians and in healthcare is an area that is deserving of focus, and we can learn a lot from other industries as well. This element of providing value is something that I think people are seeing and being more creative in, not just the obvious measures of well-being, but how can we do things like provide excellent professional development and education opportunities in a valuable way? And that valuable way might be, how do we provide it at a time and location and with flexibility that's meaningful for a modern healthcare workforce? How are we providing, education and support that doesn't just mean another 1 or 2 hours of training on top of everything else I have to do in a busy day? And finally, as I said, improving health equity and I won't delve much deeper, as Xanthina's really taken us through some of the questions of health equity in good detail there. All right, so I'll fly through the next few slides. When I think about the quintuple aim through the patient perspective, it's really the top 2 that patients most strongly consider. Obviously, themselves, patient experience, and improved population health are the things are the 2 aims that resonate the most with patients. Go to the next slide. From a clinician perspective, it's really the patient experience and care team wellbeing are the 2 that resonate the most with staff who are looking after patients as well. There are obviously flavors of, and as I said, interest in the other aims, but the 2 that are front of mind for clinicians are 1 and 4. Next slide. When I think about hospitals and healthcare providers and systems, it's patient experience and reducing costs these days that are things that are top of mind for some of the reasons I spoke about before. If I go ahead again, when I think about government perspective, improve population health, reducing costs, and that lens of health equity. Can see there, actually, if we go forward one more slide, vendor perspective, really focused, generally are pretty good at focusing on a patient experience, some little elements of care team wellbeing, and cost effectiveness is very much something that vendors and private industry is very good at having a focus on. When you look through those, actually just pop back one slide for a sec. When you look at those, and as I've run through, if you do like a quick little stock take, essentially all of the aims have at least two groups that have that aim at front of mind, except for health equity. And I think that's worth calling out, and it's worth remembering that health equity is something that is really needs to be part of a focus of governments, of providers, but also that we need to take some responsibility for. Otherwise, it'll too easily fall through the cracks and continue to fall through the cracks, particularly when we're considering digital health and digital health outcomes. I think, I certainly wouldn't be the first person to say digital health and digital health advances have got the opportunity, provide the opportunity for us to make some of the most dramatic improvements in health equity that we've ever seen, but also, if we don't pay explicit attention to it, could massively just increase an existing divide as well. So worth calling out from that point of view, that of those stakeholders other than government, that we also need to be paying attention to that. Next slide. So now I'm going to go back to myself and speak for the areas where I've most been involved with in my career. So from a patient perspective, what's valuable to me? Well, when I'm navigating the system as a patient or carer, system's stressful, it's scary, it's confusing and disempowering. And it can be those things even for us who are used to navigating the system. So I think about people who don't have that experience. So how do we see value? It's really inward looking when we're patients. How does this make my health better? How does this make my life easier? How does this look after my family, my friends better? Does this thing make the system that's challenging easier to navigate? And then that other bit around prems, does my care team listen to me, treat me with respect, and communicate with me in a timely and effective manner? So from there, some of the greatest areas of impact by digital health: accessibility, connected care and data, information provision and navigation. And to put some solid examples around that, things like a single digital front door, access to my own data and results wherever and whenever I need it. The ability for me to feel like I've got ownership of my own information. Those are the things that I care about as a patient. Next slide. Popping doctor hat on now. What's my experience of the system? Often it's too much work and too little time, increasing demands. I've also got this sense of responsibility. I know that I'm in a role of high risk, high stress, high responsibility. And there's patient and hospital expectations that weigh on me heavily, appropriately so. This is serious business. So the things that can provide me value when I'm being a doctor, it's really practical and patient-centered. And to be honest, I say this time and time again, you can boil it down to, when I look at most things that I'm being provided, if someone says, hey, we should do this, or have a look at this, when I'm thinking about my work, it's what's in it for my patients or what's in it for me. And there's lots of different things lots of different potential answers to that. But when you boil it right down, what's in it for my patients or what's in it for me? And then some of the side questions. Does this help with my work-life balance? Does this allow me to do my job better in a shorter period of time? Particularly for junior clinicians, does this help me learn and progress my career as well? And does this let me work at top of scope? Does this take away some of the things that I do at the moment that I feel like I shouldn't be doing, that take me away from providing patient care? So there's some obvious areas of greatest impact by digital health. Improving and smoothing communications, allowing people in healthcare to communicate with each other, with patients, and with other stakeholders more easily. Access to information, so obviously EMRs, health information exchanges, etc. Decision support, and obviously the takeoff of generative AI, in particular allowing improvements in efficiency of generating clinical documentation in a timely, effective manner. Next slide. Now, I'll pop my executive hat on. Again, it's a really different view when I sit down and think about it like that. It's the constant pressure to provide better and better care on a decreasing budget, to be blunt. Again, appropriate, we need a more sustainable system, but that's the pressing lens. So how do I see value? It's about things that are that provide strategic, operational, and I should have put quality value there. So how does this make us as a group, whatever group lens I've got on this, how does it make us more efficient? How does it make us safer? How does this make us a more attractive employer? How can we attract really good people to work with us? How can we keep our own people safe, happy, and wanting to stay working with us? So some of the areas of greatest impact by digital health, from when I've got an executive hat on: cybersecurity, billing, revenue, coding, reporting, analytics and AI, those sort of more system issues. Go to my next slide, and I think coming towards the end here, Chris, sorry, I'm mindful of time. So when I think about assessing potential values of a digital solution, the things that I do and what I would suggest others do, whichever world you're working in, just think about all the different perspectives. It's really easy to just go, this is what I'm doing, this is my hat, and this is what I'm focused on. But just broadening that out to go, okay, if for something to really, really work and be really, really effective, you're pretty much never in a silo. You're going to be engaging with more than one group of stakeholders. If you do something with digital health, you are, even if it's really clinician focused, it's going to affect clinicians, but also the health service, hospital system, private practice, general practice, whatever other system they're working in as well, at the very least. Most of the time, anything we do with digital health will have some meaningful impact on patients as well. It won't be purely inwardly facing. So just think about, work out who you're providing value to, and remember that almost always it's more than one particular person or group. Work out what's potentially important. Ask. Co-designing and developing, preaching to the converted in this group, that's for sure. But it provides that, again, that focus on why, co-design and development, just asking what's important to you and bringing that into the room early is important. And obviously, again, starting with the problems, the drivers, what's valuable, and building fit for purpose solutions rather than the other way around. Next slide. I think that wraps me up there, Chris. So I'll stop there and hand back to you.
Thanks very much, Michael. Some really good food for thought there. I think one of the greatest challenges for us in prosecuting this agenda will be the fact that digital health is much more likely to impact multiple stakeholders at once than a hypertensive drug, for instance. And how do we use these value assessments from the world of here's a new drug into this more complicated scenario where multiple stakeholders are affected? And we'll talk more about that as we go through. Thank you very much, Michael. There's a question already there for you, Michael. And again, it's a good time if people want to pose questions to Michael now that he's finished talking, and you have access to him for the next little while. I'm now going to hand over to our next speaker, who is Katrina Neve. Katrina manages the Loddon Mallee Virtual Care Office at Bendigo Health and has been driving virtual care technology in healthcare in regions for quite some time. First met Katrina at our Alfred days when she was the HIF manager. It's now about 10 to 15 years ago. And I've always been really impressed with the work being done up in Bendigo. And it's one of the reasons I've asked Katrina to come along, and as she has over 20 years experience in this field and began specialising in digital health in the last decade. I'm so pleased Zamfina raised the issue of equity. In order to address equity, having people like Katrina tell us what they're doing in the regions is valuable. Going and visiting the regions is valuable. Having an open dialogue is valuable. So I'll get off my soapbox. Over to you, please, Katrina.
Thank you, Chris. And thank you, everyone. It's really lovely to be here today to talk about, as Chris said, the experiences that are underway within the regions of Victoria, and in particular, the Loddon Mallee. Next slide, please. I will quickly acknowledge the traditional owners of the land. I'm coming from Dja Dja Wurrung country today. The Loddon Mallee itself, next slide please, is a fairly significant geographical area within Victoria. So it's the northern east-ish most region of the breakdown of the regions within Victoria. So we actually cover 25% of the state geographically, whereas we've got around about, I think it's just over now 6% demographically. So we're very familiar with the tyranny of distance, and I too am very pleased to see that theme come through around equity of access. It is a really significant challenge for all regional settings. Loddon Mallee is certainly a good example of that. You can see there we have the 15 health services. We also have the breakdown of the different local government areas as well. So access to care is always an ongoing challenge, particularly around specialist services. It's also something that has a fairly significant impact in terms of workforce challenges. So workforce shortages, the well-known and acknowledged GP crisis is more significant the further out of a metropolitan setting that you do get. So that is an ongoing challenge for us. I too have a personal connection to this work in the sense I grew up in the country with a member of my family who had chronic illness in a rural setting. So very much driven by that desire to be able to continue to advance and equalise where we can to provide people with the appropriate amount of access to care virtually if there's no other opportunity to do so. So next slide, please. A little bit of a timeline. I won't labour on this for too long, but just to give some background and context to the Loddon Mallee, there has been a really long established history of collaboration within the health services that very much preceded the health services partnerships that were established within Victoria a number of years ago now. There has been a need really in the region, and has there been in many other regions, to actually collaborate in order to be able to create economies of scale across health services. So there's been some really good examples of that, not the least of which was the establishment of what is now our Loddon Mallee Shared Services, so an alliance effectively across those regional health services to be able to provide digital services across the region. So that's something that's quite mature. There has also been some regional investment around architecture and the underpinning of regional infrastructure effectively to be able to then deliver what I'll go on in somewhat of a case study actually to demonstrate what we've been up to in these last few years. They did, pre me, well prior to me, there was the investment in what is known internally as our regional community platform, so RCP internally. I'll talk a bit more about that as well. We've also had a really strong history of shared services that are delivered virtually, such as Gero Connect, which many people would be very familiar with. There were a couple of other major milestones there. The telehealth project that was run across the entirety of the state. The recommendation out of that was the establishment of a virtual care office, which is how our service came to be. And then obviously the Better at Home project, which we actually leveraged some of that capital funding to be able to invest in our remote patient monitoring systems and technology, which I'll go through shortly. And obviously COVID. We can't not mention COVID. What that meant for the regions actually was a little bit of a different experience than it was in the metro settings. There was a little bit of a lag in terms of technology availability beyond the metro setting in the region. So what we did within the Loddon Mallee was to actually create collaborate with the public health unit as well as with the vendor. Our vendor, I'll get to in a moment, but we had a really strong partnership, an ongoing partnership there to be able to develop our own module, which was rolled out really quickly, which we've then continued to leverage on to be able to implement remote patient monitoring. So next slide, please. So I will go through a bit of a case study effectively in terms of how we're utilising digital health to be able to add value to our communities through the collaboration that already exists and continues to strengthen across the region as a whole health network. Next slide, please. So our version of remote patient monitoring, we have implemented in 10 of our 15 health services to date, with all of them expected to be live and utilising the system by the end of this financial year, ideally a little sooner. The technology that we have in use is, as I said, in partnership with data capture experts. So the DC2 View is the product that is being utilised for this purpose, and that is also the platform that's used as our regional community platform. So leveraging existing was a really strong benefit for us. In addition to that, the investment of capital funding that came through Better at Home meant that we could invest in the integrated clinical equipment, which I'll show you in a moment as well. So we are focusing on chronic disease management in the community within our health services that do vary in scale. We have a number of regional larger scale health services, but also a number of rural health services, majority of which their care is delivered in a community setting. So there's a lot of outpatient care delivered. There's a lot of movement across our region in terms of accessing specialist care for patients, as well as our clinicians also move around the region a little bit also. So with remote patient monitoring, just to quickly go through the functionality that we have implemented, we have a patient portal that is utilised by the patients on their own smart devices. We have integrated clinical equipment, and that then feeds back through to the dashboard, which is built into our regional community platform. So there's a module within the platform for the clinicians. The functionality itself is obviously the biometric readings, with the ability to send those readings throughout the days. Then also survey functionality, which we're finding really effective and looking to expand further and further into. For example, that will be our mechanism, that is our mechanism for how we capture patient-reported experience and outcome measures. We also have messaging functionality, which has been a really well-received element to the functionality and to the application itself. It is something that we do get the strongest feedback from our clinicians and from the patients, in terms of the patient level of comfort in knowing that they can send a message and have their care team receive that, obviously with the right safety mechanisms in place around what's a message versus a phone call. We currently have over 250 patients across the Loddon Valley region who are accessing and utilising remote patient monitoring on a daily basis. That's our concurrent usage currently. And once we have all patients on board and then continue to expand into other areas, where we're looking forward to having sort of up to 500 patients at a time utilising this system. We also are undertaking an evaluation more formally. So we've obviously got our internal evaluation underway. I don't have much in the way of data to present back in this setting. However, I am really pleased to say that we have just undertaken and have commenced a partnership with another university, actually. Sorry, Chris, I'm not sure if I'm even allowed to say that, but we have, to have an industry professional doctorate candidate start, who'll be helping us with the evaluation, and we will obviously be focusing on the clinician experience and satisfaction, as well as obviously the patient and consumer satisfaction, but also looking at providing that operational and health economic evidence, so that we can continue to, provide that evidence for expansion over time as well. Next slide, please. I know most of you on the call, I'm sure, are very familiar what the evidence base is behind remote patient monitoring, but just to go through some of the highlights, I suppose, in terms of obviously the facilitation of earlier detection of clinical deterioration is a really significant benefit to having patients monitored in the community. We have many instances already. Effectively, this approach in using remote patient monitoring for the use of chronic disease management in the community is focused on the reduction of potentially preventable presentations and hospitalizations that could be avoided. So that earlier detection for patients with chronic disease enables that earlier intervention, earlier enacting of action plans, for example, with the support from the clinicians themselves and the clinical teams. Improving that access to care, we're really looking to as we work with each of the health services, particularly the community-based services. And again, back to our tyranny of distance, we have the ability to provide them with the tools so that they're actually able to provide care to more patients within existing resources by, reducing the need for visits that perhaps aren't necessary. And when we talk about visits in the regional setting, we're talking about a decent amount of travel as well. So again, that efficiency, which obviously has knock-on effects for not just the patients, but also family members, lost time, attending and taking people to appointments, those sorts of things, which in our regional setting is often also our staff members. Very interesting. Obviously, building that engagement with the patient and their clinical team is one of the things that we hear come through most strongly from our patients, in particular from the health services themselves. They do talk about the patients having that increased confidence in just knowing that someone's looking at the results as they come through. Patient education and increased health literacy is, very well evidenced in terms of one of the key benefits for remote patient monitoring. And we are seeing consistent, again, feedback and input from patients around actually understanding what their numbers mean now as they're taking their readings day to day and what those trends look like, and attributing the individual behaviours or changes in their condition to the numbers and translating that. So that increase in health literacy for those with chronic disease is really significant. That sense of support I've spoken about, and again, that efficiency and the ability to, in theory, deliver care to more people with the same amount of resources in that non-admitted space especially. Next slide, please. So I mentioned the integrated clinical equipment. So we did utilise the Better at Home funding that was available to purchase and then provide to the region the clinical equipment. So we obviously went through that procurement process and are utilising the iHealth devices. Those actually Bluetooth into the patient portal app, and then feed those readings through to the clinician's dashboard for them to be able to view. That was again done in partnership with each of those vendors, and we're really happy with the current position and the usability of the devices themselves, but also obviously of the patient portal. We also have the ability to configure the observations equipment with the patient's conditions. So it's very rare that the patient will go home with all of these equipment. It is able to be tailored down to that individual readings required effectively. Thank you. Next slide. So just to explain structure a little bit, the virtual care office, so my team and I, there's literally 3 of us. So we're not a very big team, but we think we managed to pack a bit of a punch. The way that we do that is to actually provide that support directly through to the health services and the identified clinical services within, who are effectively taking on remote patient monitoring as a tool that they use in their services. So the patients remain under the clinical governance of that health service. They, are overseen medically as they would be in the same way within that service. So there's not a central monitoring service at this stage. This is a decentralized model that we have implemented and established. So the clinician's experience is that they actually identify the patients themselves. A lot of our health services are very aware of the patients that do return more frequently back to ED, for example, or their urgent care setting. So as we go to work with our health services, depending on the scale of the health service, often they can come up with a bit of a list in their head, or obviously go through and mine that data in terms of the patients that they know can benefit the most from that. The patient is then provided with all of the appropriate information, and there's an onboarding process there in terms of obviously consent provided, and there's a lot of education that comes at that point from the health service clinicians around, again, how to utilise and to still call if there is any concern. So it is an adjunct as opposed to, introducing new care mechanisms necessarily. The plan of care is developed, and the clinicians are then responsible for that daily monitoring of the system itself. Next slide, please. So just a quick little snapshot of the clinician dashboard. I know there's, we've probably seen examples of this before, but this is the example that we're using. So again, the only thing I'll point to on that slide is the clinician status. So the coloured icons along throughout the middle there, which enables this to be able to filter the patients who have got a reading or several readings outside of range, so that we can actually then, clinicians are able to prioritise their care as they go through, and if there's nothing to see, nothing to respond to, then they don't actually need to do anything for that patient on that day. Next slide, please. That's the next level down is actually the patient's view. So for the clinician dashboard, but when they're at the individual patient, they're obviously able to get in and view those observations as well as the messages and any responses to surveys. Patients are actually able to provide a comment and attribute that to an individual reading, which is also something that's really helpful for particularly, again, it's able to be tailored to the individual person, so that it could be part of the care plan that there is something that is a particular, something that they add comments to. A good example is we're using this within diabetes in pregnancy. And if there is a slightly higher reading, sometimes there's a comment attributed going, yeah, but I had some cake, so don't worry, I'll just test it again in an hour, for example. And again, that ability to view things in different ways for the clinicians to make the most of that data that they have available to them. Next slide, please. So in terms of the patient's experience, obviously their experience is not with the virtual care office, it is with their clinical team directly. We have gone through a co-design process in terms of the development of all of this functionality with our consumers and with clinicians that we continue to revisit and evolve. But effectively that the patients are informed about, educated, and then provided the opportunity to participate or not. And then they're provided with some technology support by the clinicians to actually download the app and get them set up, which we've streamlined to the best of our abilities, but it is still an existing step that is an ongoing one. Next slide, please. So these are just some screenshots of the patient portal itself, just to give an indication of, again, we have gone through and will continue to have a commitment there to have a continued evolution of what the actual patient portal looks like. At the moment, I will note we're only using the patient portal for remote patient monitoring, but obviously very aware that there's many other ways that a patient portal will has the opportunity to benefit and add value. So looking forward to continuing the expansion of that beyond remote patient monitoring. But you can see there that there are the connected devices that are Bluetooth connected in, and then there's the patient's view of the vital signs, as well as the surveys that they're sent to respond to and their ability to message, either initiate a message or then to actually reply back to one if there has been a clinician. The surveys we are especially excited about, a bit excited about all of it actually, but the surveys we are looking forward to when we start moving beyond chronic disease management. In particular, thinking along the lines of community palliative care or perhaps community mental health, around the ability to leverage that survey functionality where the biometric readings perhaps aren't relevant or as relevant. So looking forward to sort of continued expansion in that space as well. Next slide, please. So in terms of bringing things back to, how we are focusing on adding value for the patients and for in our instance, the health services, obviously themselves, we are aiming to ensure that, with remote patient monitoring, it does actually support the collaboration and coordination of care within a health service. So by using our existing platform and adding functionality to that, it actually means that the clinical data from remote patient monitoring is viewed alongside the rest of their clinical documentation for their outpatient care. So their discharge summaries, clinical documentation from the rest of that episode of care, as well as existing appointments. I mentioned before that the care plans are able to be designed at that patient level. So that process is, as it often is on the point of admission to that service or onboarding onto remote patient monitoring, making a very clear plan with that patient in terms of how and why remote patient monitoring is being used, to what end, what are their clear goals, and then the revision of those goals as well with their clinicians over the period of their care. Often, as I said, remote patient monitoring is being leveraged to be able to identify earlier identification of clinical deterioration, to be able to then facilitate earlier intervention. And we've had some really good individual case studies come through in terms of some individual patients who were perhaps quite resistant to having additional visits in their home, which made it very difficult to be able to manage their care appropriately. But with remote patient monitoring, it meant they didn't need extra visits, and they were very happy to upload their data each day or several times a day, as long as we left them alone and didn't go and visit them more often than they were already being visited, for example. There was also also another patient who took her patient portal to an appointment. She was having a workup for transplant team at the Alfred, actually, Chris, and she was able to literally go, here's my obs, here's everything that you need to know about me, which is fantastic. Literally putting the information in their own hands is obviously incredibly powerful. And again, their ability to engage with their clinician, with their clinical team whenever they feel that they need to is something that's again being received very well. Next slide, please. So in terms of outcome measures, as I said, I don't have data to present back to today. However, we are undertaking evaluation, as you would expect, in terms of patient-reported experience and outcome measures that will obviously be valuable at that health service level, but also looking to have that collated view across our region as well, to be able to then obviously provide back evidence of the success to date, but also then looking at how we can continue to leverage and expand as well. That focus on increase of self-management and health literacy, again, is where the significant evidence sits in chronic disease, but hoping to be able to sort of replicate, potentially look to expand some of that also. Next slide, please. So from a cost effectiveness perspective, there are challenges, I suppose, in that space. In our setting, at least, it is a difficult thing to show direct evidence of avoidance. We are looking at it's a difficult thing to set a KPI for at an individual health service CEO level. Often what we are doing is reducing or avoiding a presentation to an ED that is up the road and not that local health service level. So there are some challenges there, but also obviously looking at evaluating and monitoring how we are providing that opportunity for increased efficiencies within clinical services. Another quick example, one of our very small health services who have about a 150-kilometre radius or distance between the next hospital. We had one clinician who was working 1 day a week, and one of her patients she was going to see was an hour each way. So 2 hours round trip to go and take a blood pressure. So it's a very small example in terms of N=1, but it's something that has a really significant impact in these settings. In terms of transparency and accountability, as I mentioned, we are funded. There is a collaborative arrangement across the Loddon Mallee region. So we, again, obviously had that investment through the Better at Home side of things, but there is also that regional governance, not just around the delivery of the project effectively, but also to look to see how we continue to ensure that we have established greater equity and access for our patients across the region. This really is one focus of many within the virtual care office of the region, but this seemed to be the one that offered the most significance for this conversation. We are really looking forward to expanding into other areas, utilising exactly this technology also. Sorry, next slide, if that's okay. Yeah. I will just touch on the continuous improvement side of things. So we actually had version 1 of the patient portal implemented about a year ago. We then actually worked with our clinicians and got feedback from the consumers, our patients and consumers, and there was 2 apps that were required with the actual design of the system, and it was one too many. So what we actually did was to partner with data capture experts to go back and revise the patient portal. So we now have that direct device connection, which is really beneficial from the perspective that it is the individual clinician's decision in the community service to onboard a patient. So if it's too difficult, then the ability to achieve those benefits within any one health service, let alone the region, becomes quite limited. So it's been obviously very important to be able to continue to respond to any frustrations. So we have managed to streamline that very significantly. Another thing that we're working on at the moment is the utilisation of patients' own devices. I'm not sure when the last time anyone else picked up someone else's phone lately and tried to actually navigate with it. There are definitely challenges in that space. So we're looking at whether whether or not we're able to provide devices as well, so that that can actually not be an inhibitor for anyone being able to access. So again, back to equity of access. If people don't have a smartphone, we don't want that to be a reason for them not to be able to benefit from this. And the next slide is just around our opportunities, and again, just for remote patient monitoring, but we do have a range of other initiatives we're looking forward to as well within the region. And again, always doing so with a collaborative regional focus. But in terms of the additional clinical cohorts that we feel could have benefit from remote patient monitoring, community palliative care, community mental health rehabilitation, there's also obviously the ability to continue to add additional devices. And then virtual wards is something that we're very much looking into, and there has been some success already within our region with 2 health services partnering and very much looking to increase their access to specialist care within their local area through the use of virtual wards in a smaller health service. So that's something we're also looking to continue to support from within the virtual care office. And I think that's all.
Wonderful. Thank you very much, Katrina. Really appreciate it. I hope that gives people something of a sense of the journey that's been undertaken up in the Loddon Mallee region and in Bendigo in recent years. There's actually a whole sequence of things that have happened there, culminating in the program that Katrina has spoken about today. And I will pick that up in questions after the break as well from myself, if not from others. We're running very well on time. We actually have a bit of buffer time in our schedule today. What I would suggest we do, according to my clock, it's 2:30 p.m. Australian Eastern Daylight Time. What we might do is have our scheduled break now for the next 15 minutes, and we'll actually come back at 2:45 p.m. So 15 minutes from now. I think we may even have some overseas people. So 15 minutes from now, we'll resume with our panel. So it gives you a chance to think of questions you'd like to ask. And we'll also be joined after the break by Professor Ming Luo on the panel, who I will introduce when we come back in 15 minutes. So please have a coffee, bathroom break, a snack, and please come back with us in another 15 minutes. Okay, everyone, we might make a start again on our panel session. You've actually got a couple of questions in there already, Katrina, if you wanted to make a start on one of them, and anything left over we can come back to in a second. We've already met today Associate Professor Michael Franco and Katrina Neve, and we anticipate Professor Zanfina Ademi Delaney will be back on with us shortly, but I'd also like to introduce now Professor Ming Luo. Ming is the Director of Radiology at the Alfred Hospital, but also a Professor of Radiology, Electrical Engineering and Computer Systems Engineering at Monash Uni, based in the Department of Neuroscience within the School of Translational Medicine. And Meng also directs the iBrain program, which is the bioinformatics research in artificial intelligence and neuroimaging. And I know some of my FIT colleagues work with Meng. I've also wanted Meng to be an attendee today because he has been one of the people at the forefront of AI in radiology. And we've been deliberately agnostic of technology in a sense in thinking about value today. There are many examples of value potentially or actually being delivered from a whole bunch of different technologies, but I think AI is an interesting case study when it comes to value, and there's no doubt the area of actual operational healthcare and medicine that it's made the most headway in is radiology. So Ming, with that in mind, I'm going to put the first question to you. You're currently on mute, but I'm sure you'll fix that in a second. Where is AI in radiology yet? Has value been delivered? What does that look like? How have you measured it?
Yeah, thanks, Chris, and thanks to the speakers for very thoughtful and interesting talks. Yeah, so I guess Australia is a little bit behind the rest of the world in terms of certainly the development and implementation of AI in radiology. I think there are multiple reasons for that, but we'll come back to that in a second. I think going on from what the speakers were discussing today, there are probably 3 or 4 benefits in terms of value of AI, and you can kind of list them in terms of patient safety and patient care. The second would be a combination of patient safety and reducing variability and improving efficiency from the physician's point of view. And then the third is probably improving efficiency in the hospital, so patients can actually get care delivered, and also in the community setting, and get care delivered very efficiently, so they're not sticking around in the hospital for days and days, or in the community for days and days without a more accurate diagnosis. And that progression of care, I think, is really important. So just to give you some examples, obviously, if you're a patient coming to the ED, you could see a number of different doctors, 3 or 4 different doctors, and just because of the nature of doctors, the care that's delivered could be variable depending on the doctor that you see. Similarly, the diagnosis that's being made, if you're having imaging, could be slightly different reports from different radiologists, and then as a result, the care and the outcome may potentially be variable. So the patient variability, I think, can certainly be reduced, and as a result of that, patient safety can be reduced by implementing AI. Just to give you an example of that, and this also helps with doctors in terms of managing complex patients. So I'm actually writing a grant on traumatic brain injury, and Alfred being a major trauma center in Australia, we see a lot of major moderate to severe trauma being flown in from all over the state. And an example of a very complex multi-trauma patient that may have had head injury and a car accident and so on. It's difficult to actually assess this patient in terms of the imaging, the bloods and pathology and so on, and to figure out what kind of subgroup this patient with moderate to severe head injury might have. And then as a result of that, because we can't make an accurate assessment because of the diagnostics, it's difficult then to create a good management plan. Patients might be intubated and unconscious in the ICU for a few days or even longer than that. And as a result, the management from the clinical team is very, very challenging. But because there's so much diagnostic information now, from imaging to bloods to clinical information and so on, I think the application of AI, which is the grant that I'm writing at the moment, to actually integrate all of these findings, which is very difficult for a human to do. So integration of large volumes of clinical data, imaging data, and biochemistry and pathology data, I think will be much more efficiently done and also more objectively done, reducing, again, the variability using AI. And then the last piece is the hospital efficiency. So not only is there potentially hospital efficiency for workflow, so reducing length of stay in the hospital and reducing the cost of taking care of a patient in hospital. I think that's also really important. So probably those 3 or 4 things, Chris, I think is where AI has value. There's probably a few others, but I'll probably stop there and see if there's any other questions.
So, Ming, you've actually got some operational AI in your workflows at the Alfred, correct?
Yeah, we're the first to, because I don't know if people can hear my pseudo-American accent, but I spent 20 years in Los Angeles and in New York, and the US is reasonably progressive in terms of the adoption of clinical AI. So when I first came back, I think we were one of the first hospitals in Australia to adopt some of these clinical AI tools. So I've written a couple of papers on, for example, using AI to detect brain hemorrhages. And the advantage of something like that is that it increases the efficiency, and it also helps our radiologists, provides them with a bit more confidence, and also potentially a teaching tool for our residents and our trainees and our registrars.
And let me push you further. If somebody high up in your hospital came along and said, we want you to stop spending money on AI, what would you stand in front of and not let them take away? And how would you justify it in terms of the outcomes?
Well, the big question is whether, in any, whether it's healthcare or engineering or finance or fintech or, the real concern is the replacement of human healthcare workers, everything from doctors to radiologists to nursing staff. And we see already at the Alfred, we have a big project that is going to implement a GE command center, which sounds a bit like the command center at NASA. And in fact, it is just like that. It's a big room with multiple screens and multiple people that are monitoring everything from the bloods to the imaging to delirium and patients, about to fall and so on. So that kind of technology, I think, is clearly will be able to gather information. But the question obviously is, how will this one help human staff in healthcare or potentially replace them? I mean, the big concern in radiology is whether AI, and I've seen some of the foundation models that are being, in fact, there's a big AI company in Australia that have developed the first foundation model using large language models in Australia. And it is quite amazingly accurate in terms of making a diagnosis from imaging. And so the question and the concern, because we have to pay humans and humans get sick, and the cost of humans doing imaging is expensive, and the cost for licenses for these AI tools is not expensive. So you could argue that there's tremendous financial value and economic value in replacing humans with AI. And in fact, one of the incentives for this big private practice radiology group that's working with this big AI company is, in fact, to be able to improve efficiency and reduce the time that it takes for a radiologist to do a report, so they can actually get through more reports. But then obviously the reports should, in theory, have less variability, so it should be more accurate. So the concern, obviously, if you're a radiologist or you're a trainee, I often get asked, if I had a child or a grandchild, would you encourage that person to do radiology? And I would still say yes, because I think certainly in the next generation or two, there'll always be need for humans to authorize and verify and validate reports, because we're not quite there yet with AI. But I can see, not very far into the future where there will be humanless healthcare and humanless diagnosis and management. And so the replacement of humans, I think, is probably my biggest concern. And it comes down to obviously costs and safety, and whether we can actually trust AI in that setting. You're on mute, Chris. Sorry. Sounded like you said something funny.
I said if that doesn't generate a couple of questions, I'll go he. So hopefully there's a few questions pop up out of that. Thank you, Ming. And just to encourage everyone, we have a decent time for this panel session. Zamfina will come back and join us. Please use the time to ask your questions. Michael, I'm going to move to you. You addressed this actually in the chat, but people mightn't have sort of picked it up. One of the challenges in IT generally in healthcare, call it digital health if you like, has always been that you can have multiple stakeholders, and the relative value or opposite for different stakeholders can be different. The classic example being EMRs, where the customer and the user are two different things, and we've seen that play out. So you described your approach as somebody straddling multiple hats at once and having executive responsibility, but being well aware of clinical responsibility. How do you go about juggling the relative value to different groups? You mentioned this in one of your answers.
Yeah, thanks, Chris. It's one of those things where it's not complex, the answer to this, but it's often difficult to achieve in practice. But I think firstly, one of the things that we always try and do is just find the common ground, because there's always going to be common ground regardless of even if we've all got our different perspectives on something. In general, we all want better healthcare in some level, at some way, shape, or form. And you can usually find areas of commonality for people. So that's the first thing that I do. And then the second thing that I do is it's really easy at times to get stuck in the middle as this intermediary and be ferrying messages and trying to express clearly the perspectives of another group secondhand. And I think, some of my greatest successes have been just putting people in the room together to hear from each other. And the biggest example of that is getting the patient voice in the room. Challenging, not easy to do. Got to get the right people, got to get the right, do it in the right safe forum. But, particularly when I think about hospital exec, there's nothing more valuable than getting the voice of the patient in the room for that, to help you know, when things are getting stuck, when you're getting stuck because you've got one group who's looking at something in one way and wants this, and another group that wants that, putting them in a room together, reminding people the areas of commonality, letting them hear each other's voice in a safe space, and remembering what your North Star is. What's the overall aim here? So, like I said, none of that's rocket science, but it's the important stuff that isn't easy to do sometimes.
Thank you, Michael. Much appreciated. Katrina, there's a question there for you in the chat from our colleague Cherie.
Yeah, I was just having a read of that. It's really vital, obviously, that we're capturing the right information, both as a baseline, but then obviously looking at the impact of what has been implemented for the existing functionality, let alone what we hope to move into. So we are very much focused, obviously, on the patient-reported experience and outcomes. We're also wanting to make sure that we're able to show evidence of efficiency within services. So the ability for us to capture when a patient's visit was not required as a result of having remote patient monitoring in place. As I mentioned, that has a fairly significant impact for anyone anywhere, but in the regional and rural setting, that can really, result in a significant impact in terms of time and efficiency for clinicians and also cost for patients travelling and family members taking time off work, those sorts of things. So we'll absolutely capturing that information. Also something I think around travel and the reduction of that, and potentially looking at how that fits with everyone's ongoing responsibilities around reduction of emissions and those things. Also looking at the successful avoidance of preventable presentations to urgent care centres and emergency departments. As I mentioned, that can be really challenging across the scale that we're working on, but absolutely something we'll be focused on, and something that we're actually looking to include as part of the patient-reported outcome measures also. Have they enacted action plans how many times over the last period of monitoring? Often we're monitoring people for 3 to 6 months at a time. So looking at goal achievement, the increase in their own sense of health literacy will obviously be a key component of that, but capturing those operational efficiencies will be really important also. If anything, it's actually about whittling down what we're going to evaluate in order to make it as robust as possible. We're finding ourselves getting a little carried away with all the things that we could include as part of the evaluation, but those will be the core fundamental components.
And Katrina, I really liked your intention to measure the impact of digital engagement on patient health literacy. Really important. Yeah, really important.
The chronic disease cohort especially is there's a lot of sort of evidence in terms of people's ability to be able to monitor their own condition over time, has impact not just during the monitoring period, but for the period post that as well. So yeah, very, very important.
And Katrina, there's something I wrote down to come back to about obviously multiple doctors across your footprint involve themselves in this program, but there's a non-trivial number at the Bendigo Hospital involved in the program. Help us understand for a minute, because there's a question that follows. What's the basis on which they spend their time? Are they specifically funded to spend their time overseeing these patients? Is it something they just choose to fit in because they see value? How does that work?
So at the moment, we're working in the non-admitted space. So we're working in community nursing programs, or we're working in heart programs, complex care, for example. So that's where the majority of the patients are currently. Those patients actually attend their GP if they become unwell. So it's actually about primary care engagement, which is a little easier actually in a lot of the regional and remote settings than it can often be in a metro setting, but it is an ongoing challenge, I suppose. We are in the process of working up to the implementation of hospital in the home and GEM at home. There is no current standalone funding, as we're all, I'm sure, very aware. So it is actually about doing work differently. So we are really interested in capturing any efficiencies that we're able to create in hospital in the home and GEM at home. Complex care and community nursing aren't required to visit their patients on a daily basis. But so, for example, in hospital in the home, we're looking at, with the addition of the increased use of telehealth, with remote patient monitoring, that perhaps there will be those efficiencies as well. That is where that inpatient medical engagement is obviously really vital. We have had a clinical leadership group engaged over the course of the last coming up to 18 months actually, to make sure that we've got that individual health service clinical engagement assured, but also that regional collaboration. So given it is a new way of working, there is the ability for partnering and neighbouring health services to work together in terms of what does that mean. Even though it comes down to individual clinical governance, there's absolutely opportunities to continue to, as Michael said, getting the right people together in the right room is really important. But you're right, there isn't necessarily a there are potential efficiencies there, but there's not actually standalone funding where it's sort of happening in spite of the funding models not supported by them, unfortunately.
Yeah, that's an important takeaway statement. It's one of the reasons I think this whole agenda is very important, is we can't get to the nitty-gritty of that stuff without the right evidence and the right way of expressing the evidence. It's one of the reasons I sort of sniffing around and landed into HTA. It's the way government in this country and many countries decide what are we going to fund. And it's an unavoidable necessity, given 75% of our healthcare is funded by the government in this country. And we all know what happens anytime there's a vague noise about breaking down Medicare. Population don't want to pay more for their healthcare. It's very clear. So we need to work with these mechanisms to find ways to get more digital into the environment. There is an anonymous question there. What is the worry about replacing humans? How long should we delay progress to protect craft groups? I won't use that particular expression there. The health system as a whole can't have it both ways. I make this point sometimes. We hear that we're going to have an ever-increasing deficit of clinicians in the same conversation we're worried about replacing clinicians. Anybody want to comment on that? That's a big thorny issue, probably its own webinar, but any of you want to have a bash at answering that, please go ahead, Michael.
I mean, a couple of quick sort of knee-jerk thoughts on that. I think the hesitation, some of it's just the natural healthcare hesitation of not wanting to make significant change unless we're confident that it's safe and effective. You know, we're one of the most risk-averse industries. Whether we can continue to afford to be that or not, I'm not sure, but I think most people, if we're looking after their healthcare, do expect some level of conservatism. So I think part of it is not not a, oh, we're going to keep everything the same as it is now. Part of it's just making sure that we do it safely and correctly, and moving at an appropriate pace. And I think, you know, the other questions for me are around making sure that we don't lose the things that are important in that clinician-patient interaction as well. I think there's absolutely no doubt that in the future, and as Chris, you and whoever's asked that question have rightly pointed out, I mentioned in my talk as well, we need to have tools that allow us to address the number of people in healthcare not being, we don't have enough clinicians. So you're right, we can't have it both ways. But it's just making sure that we bring it in a way that's safe and sensible more than anything else.
Thank you, Michael. Ming, I'm interested in your view. I mean, I would have thought the College of Radiologists has had to broach this issue at a policy planning, future of the profession perspective more than any other discipline. What's the sort of prevailing view amongst radiologists on all that stuff?
Yeah, I was just about to type an answer to that question in the chat, but yeah, I think, you know, as Michael has alluded to, there is a shortage of radiologists and shortage of radiographers and sonographers in Australia. We can't keep up with training enough of them, and it's primarily because the volume of imaging is just going exponentially upwards and upwards. And so we probably need to have augmented radiology, augmented by AI. I think that's probably going to be very important. Does it mean that they will replace us? No, I think, as the person put in the chat, radiologists will reinvent themselves. They will certainly still be needed for many, many years to validate responses and validate what AI will do. And again, as Michael has said, we're very risk adverse here in Australia, so that'll probably even take longer than most other places around the world. But I think that the role of AI will always be there, particularly in radiology. I think there's just so much that's happening in radiology at the moment from foundation models. The other thing that's happening that's very exciting that we're trying to build is medical agents and agentic AI, where actually you can have someone come through and have an AI agent basically take multiple tasks and take a patient through from diagnosis to management to treatment to rehab and which I think will probably happen reasonably soon, and that's really exciting. So whether that actually replaces multiple doctors in a patient's care, we will have to see. But it's an exciting time, and I think that as the comments have said, we difficult to have it both ways, but we'll just have to see how we deal with this technology and how it can help our patients.
Thank you, Ming. Thank you. There's a question from Swapna, which I'm interpreting as what data should be collected across the system in general to measure the impact of digital health interventions. So I'll go to each of you in turn. I think Katrina's just busy. Zamfina, maybe I could start with you, given you're back on. So with your hats on, if you could make certain data collections happen around digital health, what might they look like?
So in terms of patient outcome data or?
Whatever you think is relevant, but that might be a good starting point.
Thanks, Chris. I guess with any type of research, patients' reported outcomes are very important, but also the clinical outcomes from sort of a clinician's point of view and healthcare outcomes that the government is interested on. So, for example, let's take cardiovascular disease. For example, we are interested on reducing heart attacks and strokes. Of course, we would like to capture those outcomes, but as a patient, you would like to understand whether your quality of life has been improved or whether you will be able to return to work, and how is that going to impact. I didn't touch base on this, but I think this is very important spillover effect, impact of carers that has on a disease. And usually we don't we haven't integrated this into the decision making, but a lot of countries are moving toward that way and collecting the spillover effect, impact of carers on a burden of disease. Because imagine if you are a carer and you have a ill person at home, you have to take leave or you have to drop out working. And these are some of the important things at the societal level that we have to think when we start collecting data about digital health. Chris,
I'll go to the others on that question in a minute, but just while we're on this, Zamfina, I have a recurrent theme from you about lots of ways that the current HTA system doesn't pick up things like productivity, doesn't pick up things like equity, doesn't pick up things like effect on carers. How confident are you that the collective will achieve those outcomes? You're well inside that system. Do you feel like a voice in the wilderness, or do you feel like there's a groundswell moving that way?
It's very difficult, Chris, because the primary objective of the HTA at the moment in Australia is from healthcare perspective. As mentioned before, the sponsors sometimes submit supplementary material whether productivity is being measured, which is great, but then how is that included into decision making? It's not very clear.
Yeah.
Yes, I feel sometimes that I'm alone when I talk, but there are a lot of other health economists who measure the spillover effect and impact on carers' burden, especially for chronic diseases that actually happen in a working age population, and that actually sometimes impact more women than men as carers, and we want to quantify that. We want that to be sort of a standard where we actually capture not only paid work, but also unpaid work that a general population does and how that impact the HTA processes. I think it's a long way. With equity issues, I think we're moving forward. There is a lot of research coming out from different countries. There are a lot of bodies of evidence in terms of Health Technology Assessment International. I hear International Health Economic Society, they have specific groups that are sort of moving forward with equity and advising governments how equity can be informed or can be integrated into decision making. My fear, where I stand, I think we are going to be struggling in Australia having the workforce power to be able to quantify or review that evidence that the sponsor will submit. And usually this form of generation of evidence will start when people start to publish equity information cost effectiveness analysis. When those will start out, and then a lot of researchers will sort of ask the governments to have potentially a review or meetings. How can they facilitate things like that, like equity? But productivity has been an agenda for a long time, but it's not part of the decision making.
Thank you, Zamfina. And again, just a quick aside, I bumped into Zamfina at the Health Technology Assessment International Conference in Seville last year, and it was the most impressive conference I've ever seen in terms of providing vehicles for consumers, facilities for consumers, specific program elements for consumers, way ahead of anything I'd seen at the time in digital health or health IT. Ming, I'll go to you on this question of when it comes to digital health interventions, including AI, what data should we be collecting across the board? Where are the gaps? What should we focus on?
Yeah, I guess going on from what Zanfina is saying, we've been trying to do that for a couple of our projects now, and I guess whether we measure things like turnaround times for our reports, and certainly if we're using AI, our turnaround times from when an exam is completed to when it's reported on should be reduced, and we're seeing some of that happening now. So if it's taking 45 minutes to report a head CT scan, it comes down to 35 minutes or 20 minutes. I think that's obviously data that we collect that improves efficiency. In terms of patient safety and outcomes, we did publish a paper on the detection of brain hemorrhages using AI. And there wasn't, even though it was a 1 year kind of retrospective review of the data, didn't really show that in terms of patient safety, we missed any hemorrhages that were detrimental to the patient's outcome. So the third thing is really looking at patient outcome and patient safety. And that's, I'm not sure that anyone's done that very well in terms of the AI space, whether, implementing AI and adopting AI in radiology practice does actually reduce misses. I suspect that we'll start seeing some of that data soon. And having AI augmented diagnosis in radiology should reduce misses from radiologists who are often distracted and doing a lot of volume and so on. And then the patient outcomes. Again, this is something that we're interested in looking at, whether not just the cost analysis and financial outcomes, as Zanfina speaks about, but patient outcomes in terms of whether they actually have better outcomes in their medical care. So I think that'll be really important to collect that kind of data. One of the big things that one of the models that we're trying to work on here at the Alfred and with our faculty of IT at Monash is trying to determine and build a model to figure out which patients have delirium and which patients might fall. Falling is probably the biggest killer, I guess, in the hospital. And, there's lots of data that can be collected to figure out whether we can prevent falls from happening. And as a result, the outcomes and the morbidity and mortality of that. So I think, soon we'll start seeing some of that data, the patient outcome and the patient safety data, and that'll really inform us as to whether AI does have an impact or not in patient care.
Thank you, man. That's very helpful. Michael, over to you on that same question.
I guess, Chris, what I'd add to those comments and those ideas of what data, I think there's still, I think there's still a reluctance to accept qualitative data as being meaningful and as rich, if not richer than our standard quant measures. I particularly sort of think about, this is where I put on my Palcare doctor hat and think about quality of life. We think about things that are subjective and making judgments, patients making judgments about what treatments they may or may not want to have, with a level of complexity that I don't think we necessarily think about in other areas of care. And so I'm really interested in some of those subjective measures as well, because I think we make assumptions sometimes that, just, for instance, just living longer is the end goal, and just looking at, pretty raw measures of what good looks like. We start to move towards it with quality adjusted life years, et cetera, but moving to something a bit more rich, and then potentially now, with the tools that we've got at our disposal to be able to do, effective thematic analyses of really, really rich population wide qual data rather than quant data, I think is a really interesting place where we could go in the near future.
Thank you, Michael. Thank you. As you say, there's a long history of, qualities in health economics research, but that's one view of that quality of life. And I am encouraged by what Xanthine has said about the windows of opportunity for non-financial data to find their way into HDR processes, but it still sounds like there's a bit of a gap there. Katrina, from your point of view, you've run lots of digital population level programs. What would you like to see more routinely collected to give you the sort of evidence that you're now explicitly going looking for, I suppose?
I think for us, it really is about that, with the explicit intention with remote patient monitoring and chronic disease management around reduction of preventable presentations. It is actually looking at how we capture that across several health services and actually track that across beyond the one health service. I mean, we are one region, we are a large region, but our patients do travel. So how do we actually, patient reported is the obvious. And as I said, that's what we'll be going with for now. But that ability to actually triangulate a little and track patients around where their presentations, for example, have been, and then overlaying sort of outcomes of care through that as well, I think would certainly be useful. And I think also something there around the efficiency of clinicians, the conversations around AI and the potential threats to workforce, I say in quotation marks, but I think for us in our area, it is actually how do we enable in the best possible way for our clinicians to do the most they can within the resourcing that they have. Recruitment is a real challenge. So I think how we can actually position things that we're actually enabling the resourcing that is there and available. So perhaps a bit more in terms of hearing from them and how we actually measure that in a really replicable and robust way, I think is another component for us.
Thank you, Katrina. The RPM environment reminds me of going to the HIMSS conference in the States 6 years ago. So 7 years ago, in fact, 2018, I think it was. And one of the first stalls I walked up to was an RPM solution, right, patient monitoring solution. And right about that time, the US government announced a whole bunch of billing codes for clinicians, and they are paid just to look at the data once a month, just to look at the data. So I don't know if that's continued, but I use it as a marker and say that was done 6-7 years ago in the US. We're still having conversations about how do we tweak our models to pay clinicians to be involved in very worthwhile things like RPMs, programs that will reduce presentations. We've got a lot of work to do, I guess is my point. A question I'm going to come to you all on again. So Cecily's made a point here. Some of the consumer engagement research indicates that patients' willingness to accept AI-directed decisions about treatment will fade when the clinician is not involved. So in other words, if it's just AI recommendations, they're less likely to accept it. What do people think about that? Slightly off tangent, but not completely irrelevant. Maybe Michael, you nodded, indicating wisdom.
Yes, I will see. Look, unsurprising, it will change. I think about so many other areas. Supermarket checkouts 15 years ago all had people there. Now they don't. It's just going to take some time for people to get acceptance, and slightly less flippantly as well. Just evidence. It's the same thing as well. We need to get evidence quickly, because we know we want to move quickly. We don't want to take years and years and years to change things as well. But I think one of the areas of reluctance is that people want evidence that things work, both patients and clinical staff. In the same way that I'm not going to prescribe a new immunotherapy for lung cancer unless I can see that there's a baseline level of evidence that says, yeah, this is safe and effective and more effective than what we're doing now. I think that's what people are looking for. I think there's also, that there's this natural desire and level of comfort with having humans as part of a loop in something that's still seen as very tangible and personal as healthcare, and I think that's important. I think just sort of, again, maybe slight tangent, but playing back to and bouncing off one of the first answers Meng gave, actually, where I think there'll be great benefit, and where I do think there's absolutely room for, at least for a long time, there's plenty of room for AI in all forms and people in the mix too. It's finding the right spots for them, and what I reflect on, the point that Meng made, we have an ever increasing amount of data available to frontline clinicians. Like, I think about the amount of data that I can get about a patient, or even myself, from biometric data right through to EMR data and all the other data that you can link in between. And Meng's so right that there's so much data there. We need to make sure that we're giving people the tools to be able to interpret all of that. Like, at the moment, I can't take all that data in rapidly and effectively. And I think that's an excellent use case and an excellent example to go, all right, we don't necessarily want a person out of the loop, but rapidly the person becomes that validation and interpreter that's had this lens of AI cast over an ever increasing amount of data that helps us make better and better clinical decisions just as quickly, if not more quickly.
Thank you. Anyone else want to tackle that issue of the relative role of people alongside AI and AI coming to the fore?
I would comment as well. We're currently investigating potentially replicating some of the amazing work that's been done up in New South Wales within the Sydney Local Health District around wound care management. So again, clinical decision support with, providing that up-to-date current clinical evidence around wound care management in our setting as is in the community nursing setting, for example. It's up to 60% of the care that is delivered is in wound care management. So to be able to use AI as that clinical decision support to actually remove unwarranted variations in clinical management of wound care stands to have a significant, obviously, benefits to patients, but also a cost effectiveness as well. Wound care management, the more protracted, the more costly it becomes, both to health services and oftentimes to patients also. So I think, the way that we're looking at it is what are the problems that we're needing to look to try and solve, and how do we actually use that in a way that is, I guess, the easiest entryway into it. And obviously having that evidence generated from New South Wales is putting us in a good position to be able to hope to replicate that.
Thank you, Katrina. Any other comments on this general topic?
I just wanted, I just wanted to add, sort of aligned with Meng and Michael, it's about timing. I was talking about epilepsy project because we know that patients stay in a healthcare for 15 years without not being diagnosed if they are drug resistant or not. But with this new platform, with combined advanced imaging, with cognitive techniques and AI, we are much more better placed at the point in time across all states in Australia to be able to detect somebody that they are drug-resistant epilepsy in the first and second year of their journey. So basically, we are stopping the waste of low-value care in this instance. For 15 years, they're going from one clinician to another, but now we're providing care that is much more sophisticated and upfront that will give or deal with much more complex health problems. So obviously, when those kind of big combined AI techniques are submitted, you would need also staff to be able to be evaluate those techniques, whether they can be embedded in our healthcare system as well. And as I mentioned before, workforce is going to be one of the issues to assess those big tech AI-informed decision-making platforms. But I'm sure we will come up with something that is tangible from healthcare perspective, but also from a societal perspective. But timing is a big issue, and I think we should be collecting this, because if you are saving 15 years of moving from one health system to another by these platforms, then that's a big thing.
Zamfina, is Patrick Kwan in this project? Just trying to make
Yes, it is, but this is led via Florey Institute. So the main chief investigator is Graham Jackson. I am a health economic lead, and Patrick is an outcome lead.
And am I right in understanding, just to digress for a second before I go to Ming, that part of your role in this is to say, let's collate a suite of evidence as best we can that might be an exemplar for the HTA processes to work with going forward. Is that a fair assessment?
Absolutely, yeah. So we're collecting every possible information that we could. So not only because you might not even go to HTA process, you might actually convince state leaders to implement something like this. A similar approach would be diabetes, which it didn't go through HTA process. It was based at the state level decision making. So things like these, as big, might not even need or go through a huge HTA.
Wonderful. No, that's really good. Thank you, Zamfina. Ming, you have a view to share.
Yeah, just to echo what Zamfina and Michael have been saying, not only number one is there a lot of data to collect and to interpret for a human, which is probably not humanly possible to begin with, but the project that Zamfina is talking about, we're kind of involved with a little bit of that as well. And there's data there that is actually not really visible to humans. So if you're talking about genomics data, and there are little subtleties in EEG and so on, and even in imaging, Chris, people are making diagnosis off the raw data and off the case-based data. So we actually don't need the images, and there are abnormalities in data that's not even visible to humans that AI can be trained to detect, and that's how important having the ability to make these diagnoses are. And then eventually, if you don't need to make images to make a diagnosis, well, then you really don't need to have radiologists, right?
Sacrilege, man. It's funny. Came across another similar example. I was in Dubai a few weeks ago, and I met a guy from UCL, King's College. He was working with our Indian partners, and he was talking about the use of data off the blood machines, basically. So your standard FBE report out of a machine will give a clinician, present to a clinician their 15, 20 data points with ranges, but there's actually in the newer machines thousands of other data points the machine is generating which aren't presented to the clinician that can be analysed and might be early markers for anemia or sepsis or all sorts of things. So that opens a whole other world undoubtedly as well. Michael, you had a comment.
Yeah, the other thing that occurs to me in this discussion, Chris, is that when we're thinking about place and timing for AI, we've got this natural tendency to jump straight to, we're going to replace clinicians with AI. Let's talk about that. There is so much low-hanging fruit in the healthcare system. There is so many areas, and in those areas, we will see rapid uptake. The one that we've seen an explosion of in the last 6 to 12 months is AI, ambient listening AI scribes, right? So we've seen a huge uptake from clinicians in clinics, general practitioners, and specialists in their rooms in particular, because it's effective. It is good for patients because I'm going to stick to doctors. Their doctors can look and listen to them rather than trying to take notes on the side. Doctors and patients are comfortable with its safety because the notes can't just be the notes then need to be validated and checked by the doctor anyway. There is so many things that we can do, both in clinical and non-clinical healthcare. I think about, and something that areas that Katrina and I are well familiar with, think about the logistics and what we do with sending clinical staff around to patients' homes, running hospital and home services. You think about supply chain, all that stuff that's happening in other industries. We can be doing all of that stuff that will make healthcare a lot better whilst we're doing this other stuff, getting the evidence so that we can, get rid of human oncologists and radiologists. We've got plenty of other things we can do in the meantime. So I don't want anyone to leave thinking like, oh, we're not going to do anything for ages until we get this evidence so we can fire all the doctors.
Yeah. I won't take this as a hands up from the oncology and radiology professions to be the first up to walk the plank, but thank you for mentioning it. The way I think about it too, Michael, is if we just look at a macro view of healthcare, even in this great country, there is a huge gap between the demand we're trying to meet and our current ability to meet it in multiple dimensions. That's the space where we can apply these technologies. Let's just reduce that gap for a start. Zamfina, I wanted to cut back to you, and I don't want to put you on the spot because I know you wear a government committee hat, but I'm wondering if you're able to say, maybe the answer is no, have you encountered any submissions for digital therapeutics with your PBOC hat? So, and they may be as an adjunct to drugs, they may replace drugs. Have you seen anything in the process?
Myself, I haven't.
Yes.
But if something like this will come, it will be a joint decision between MZAC and PBAC.
Yes. Yeah, okay. So for those in the audience who aren't aware, I mean, the classic one I describe to people is a product called Propeller Health. And my colleague Grace, if she's still online, might know the Australian equivalent. I believe an Australian company has made an equivalent to Propeller Health, which is a US digital therapeutic. It's used for patients with asthma and emphysema and is basically a combination of a Bluetooth cap that sits on top of people's asthma puffers and an app. And it brings a whole suite of intelligence to the individual's management of their asthma or emphysema, with some very impressive research findings in terms of reduced admissions, reduced need for drugs, multiple other things. And it's an example that in theory could be inserted into that process, but it sounds like it would be very challenging for the process. I'm not sure if Grace is still online. Grace Lethling from And Health, but apparently there is an Australian equivalent as well, which Grace might know the name of. Just going back to our questions. Adherium, there we go. Grace has popped the answer in. So if you want to see an Australian digital therapeutic innovation, you can go and have a look at Adherium. But it's these kinds of things that have inspired this conversation from my point of view. You know, not every digital health product has a lot of evidence behind it, but some do. Some have highly robust evidence, and yet we can't sort of get them into this country unless they're going to play by the rules in a way. And part of the rules are, how do we currently approve things for payment and treatment? Did the panel have any final comments they wanted to make? I'll go around each in turn. Maybe the answer's no, but Katrina has a big beaming smile like she has something to say, so I'll go to Katrina first.
I don't know that I have anything necessarily extra to add. I just think it is, always wonderful to have a community like this come together and share. Really pleased to be able to represent the regional experience. But part of my reflection throughout, particularly this end part of our conversation, is that there's so much replication of effort, within any one health service, let alone across regions and states. So, anything that can be done to have, more opportunities like this to learn from each other, I think are fantastic. So thank you.
Thank you, Katrina. We wait with bated breath for all the data you're going to show us about why virtual care is a wonderful thing. We believe it is. We want to see your success in print as well. Meng, any closing comments from you?
Yeah, I think, Zanfina made a good point about reducing low value care or sometimes zero value care. And I think, human doctors and healthcare staff are very motivated, incentivized primarily by revenue and reimbursement. And one thing that we haven't talked about, which is a whole seminar in itself, is reimbursement for AI and digital healthcare, and that's a whole different topic. But I think if AI is powered and incentivized to provide the best care, then the reduction in low value and zero value care will be important. So that's certainly an advantage of having AI in healthcare rather than being incentivized by humans that have different incentives for caring a patient.
Thank you, Meng. Very, very wise words. And I see these kind of conversations and this sort of value-based digital health agenda as a necessary prelude to have a sensible reimbursement conversation, because we need to better describe what value we're offering through these solutions in order to know how to price it and how to pay for it. I think Michael's busy answering a question. No, he's all good. Any closing comments from your point of view, Michael?
One reflection I've got, I just end with optimism in terms of the discussions that we're having today, like a discussion like this, the questions that we're getting. This has been great. This is not unusual now. I think, I compare these discussions to the discussions that we were having about digital health 5-10 years ago. There's just a level of complexity. There's a level of maturity. I think we're moving a lot quicker than we think we are because we're in the middle of it. So I just love that we've moved to these layers of complexity, as well as just a whole lot of, obviously we know there's a lot of technology and opportunities, but I think we're moving in terms of mindset, both within and outside healthcare, really nicely to be able to progress well.
I agree, Michael. I agree. There's a whole, again, another seminar about, is healthcare really slow and resistant, or does it move faster than we think it does, and the different dimensions of that, but we can do that another time. Zanfina, any closing comments, reflections from you?
No, I concur with every speaker today. I think this has been a great opportunity to discuss. I do remember when you advertised this, you said that there are so many apps there available and we don't know really how they work. And I think here we're debating and discussing what kind of outcome we should collect to be able then to determine which is better, the standard of care or something that digital health is enhanced. And I think these kind of gatherings help even further to make crystal clear that digital health should have its own HTA processes.
Wonderful. Thank you, Zamfina. And Zamfina, I really appreciate someone like yourself. It's very easy for experts in areas to stay in their comfort zone and not sort of move into the next domain. And we need us all to come together on these things. We need the kind of deep expertise people like you bring, because we're not health economists, but we know it's part of the answer here. So thank you, Zamfina. I'd just like to thank everyone again, Katrina, Ming, Zamfina, and Michael. Thank you all so much for your time. Thank you to our attendees. Inevitably, we dwindle it, but there's still 60 or so of you online. Really appreciate your time. There will be a recording of the webinar available in due course. It should only take a week or so, and you should all get links to that. And I want to also thank the team behind the scenes who help us do these things. So thank you to Heather and Lucas, Ankit, Emmeline, Victoria, and all the people involved in the Monash FIT events team. We will have some further more public events later in the year. We do about 3 of these from a digital health theme perspective across the year, so please look out for those. But I'd like to make this kind of value-focused conversation one of those 3 or 4 annual external events that we do, because I think it's only going to get more interesting and more intricate as we go along in order to solve the problem. So thank you again, everyone. Thanks for your attendance. Thanks for everyone who participated, for your time and expertise. Really appreciate it.
Thanks, Chris.
Thank you.